Hi, I'm Rob Hegele from the University of Western Ontario, where I'm a professor of medicine. And over the next few minutes, I'm going to be talking to you about some recent developments, recent concepts in the genetics and therapies of dyslipidemias. And it's just amazing how far we have come over the past 3 or 4 decades. These are my disclosures. So the objectives are actually really simple, so that I'm going to be talking first of all about hypercholesterolemia, which is basically LDL problems, and I'm going to be reviewing diagnosis and the role perhaps even of genetic testing in diagnosis. And then similarly for the other main lipid disturbance, hypertriglyceridemia, similarly the role or sometimes not the place of genetic testing, and then also therapeutic developments that give hope to our patients. So this was the status of familial hypercholesterolemia back about 3 or 4 decades ago, so in the 1980s, and this was when I was in medical school, or as an intern and resident at Toronto General Hospital. So FH was, classically it's a 1, and by the way, this is still what a lot of people think about FH. So it's a 1 in 500 disorder. It's an autosomal dominant trait. It's the Ldl receptor gene. There's the classical physical findings that you find, and you make the diagnosis based on clinical grounds, so the physical findings plus the family history plus the elevated LDL. And then the treatments, back in the 80s, we were starting to get, statins available, and then of course we had the bile acid resins and all these sort of very primordial treatments. If we flash forward to today, the status has changed. So first of all, from population studies, we know that FH is much, much more prevalent than we used to think. It's at least twice as prevalent, maybe 1 in 250 based on population screening. In some populations, even more, even like with these founder populations, such as South Africa or the Middle East, or even in the province of Quebec in Canada. And we know that the genetics is more complicated than we used to think. It's not just simply a lot of it is, autosomal dominant, but it's not just one gene. There are other genes that can cause a similar phenotype. And then there are versions of the phenotype that come into the clinic that are not based on a single gene. It's actually a polygenic effect. And we understand the basis of that, and we can actually test for that. The clinical features are largely the same if the LDL elevation is high enough, and this is then more typically in the monogenic form. And we can now incorporate DNA testing, and certainly I've been doing DNA testing for a long time on my patients. We've tested over 4,000 patients. So this is, for me, the DNA testing is almost like part of the physical exam. I feel like I know my patients better when we do their genomic testing. And then the treatments that are available, a lot of them are those foundational treatments, diet and lifestyle, and then apheresis for severe hypercholesterolemia, statins, but then we have way more treatments, fortunately, and that's, offering hope to our patients. So not only do we have the monoclonal antibodies, but we have now RNA-based treatments that some of them are absolutely amazing and really offer, again, hope to our patients going forward. Similar sort of pattern for hypertriglyceridemia. We used to think it was like super rare. The idea was that this is like a 1 in a million disease if your triglycerides are over 10, and is like an autosomal recessive, and it's like homozygous, and Mendelian, and LPL or ApoC2. ApoC2, of course, the seminal work at St. Mike's Hospital in Toronto, the discovery of ApoC2 goes back to Toronto. Lipoprotein lipase, of course, and then, the physical features of which, say, acute pancreatitis is the most severe, and then some of the other clinical features of severely elevated triglycerides. The diagnosis was then largely clinical and biochemical, and then there were, some treatments available, but not really efficacious treatments. If we flash forward to today, we know that triglycerides over a level of 10, or say 1,000 milligrams per deciliter, this is much more common now. A population survey that we did in Ontario shows that it's about 1 in 500 people. And it's not just a single gene. So when there is a single gene involved, it's not just lipoprotein lipase or ApoC2, there are other genes, ApoA5, GPI, HBP1, LMF1. And then also we know that a lot of these patients with huge triglyceride levels over 10, have got polygenic risk. They've got this high polygenic score. So I'm going to talk about that a little bit later. But then when triglyceride levels are high, the same kind of clinical manifestations. So the GI manifestations, anorexia, nausea, vomiting, the risk of pancreatitis, hepatosplenomegaly, then the physical features, lipemia retinalis. The other thing that we know is that these patients with severe hypertriglyceridemia also have increased risk of heart attack and stroke, atherosclerotic cardiovascular disease, and that was pretty clear. That wasn't as clear back in the day, but now we're more certain about that. And like I say, we use DNA to help us make the diagnosis. Not just now, fortunately, not just diet and lifestyle, and the older treatments, but we do have new things on the horizon. In particular, two of the targets that I'm going to be talking about in a few minutes, anti-ApoC3 and anti-ANGPTL3 drugs. So this was the way when I was in med school. This is what we learned about the classification or ontology of dyslipidemia, Fredrickson, right? So I just want to tell you that no, we don't do that anymore. Okay, there's no need to do that. That we have a different way of looking at lipids. So in 2021. And this is sort of my proposed way of looking at lipids, is that what's the primary lipid disturbance? Is it LDL? Is it triglyceride? Sometimes it's a combination of the two. Is it HDL? But what's the qualitative nature of the primary lipid disturbance? And then, we can classify this quantitatively. So is it mild to moderate? If it's mild to moderate, so I'm showing now in this slide some cut points, both in milligrams per deciliter and millimoles. Usually when it's mild to moderate elevation, there's not such a strong, monogenic effect. There is polygenic predisposition, and there are often then secondary factors that you know about for the lipid elevations. And then you can get severe elevations. So severe elevations would be like your LDL over 5. That's when in our guidelines, we start to think about, could this be familial hypercholesterolemia, or your triglycerides over 10, where the risk of pancreatitis starts to go up. And then for HDL, I'm not going to be talking as much about HDL just for time reasons, but low HDL, there still are these genetic deviations of HDL. In those cases, we work on improving the ratio with the atherogenic lipoproteins. So DNA variation, okay, so here DNA variation then comes in two kinds of varieties that I think of. So you can have the rare DNA variant. So this is then what we typically think of as a quote-unquote mutation. So when you're looking at a piece of DNA, like the sequence, then most of the sequence is the same between the mother's allele and the father's allele. But then again, you'll reach a position where there is a variant, a change, a quote-unquote mutation. And if it's a rare variant, so this, to the sequencer it looks the same. But what distinguishes it is the frequency in the population. So if it's a rare variant, then this is it's more, these are more likely. They still can be neutral. I mean, in fact, most of them are neutral, but they are more likely to be disease causing. So this would be then like the mutation, the heterozygous mutation in the Ldl receptor, that single change in the DNA code, and it's enough to screw up the function of the receptor, and then the patient develops all the complications. So that's a single letter change, and that's the rare variant of large effect. And that's when we think of, Mendelian monogenic disease, that's what we're thinking of. And so the monogenic dyslipidemias, remember I see there's you can break dyslipidemias down into, is it an LDL problem or a triglyceride problem or an HDL problem? So now we pretty much, and then furthermore, is it increased or decreased? We now pretty much know all of these now. There may still be some more to be discovered, maybe. I never say never. But I think we pretty much understand all of these monogenic dyslipidemias. And these are the genes that are shown here where, as in the prior slide, you get a single mutation, and that's enough to fully explain the phenotype. And you can then you can put them in a table like this. So then this shows the name of the disease, the name of the gene, the position of the chromosome, the genetic identifying number. So these are the high LDL disorders, the low LDL disorders, the high triglyceride disorders, the low HDL disorders, and the high HDL disorders. It turns out there are 25 disorders and 25 genes. Now, it's not quite a one-to-one match. Some genes actually can cause more than one disorder. Some disorder are caused by more than one gene, but just by chance, it works out that there are 25 genes and 25 disorders for these monogenic dyslipidemias. This is the genetic map of where they all map in the genome. And, then of course, sometimes if the elevation is really severe, it's present from birth or present from being in utero, the patient can develop physical signs, and these are all then summarized in this slide. So some of the physical features of a severely elevated LDL or a severely depressed LDL or severely elevated triglycerides. So those are all there. And then, if you want to read more about it, the reference is there. Okay, so let's talk about a case of mine. This is a patient, he's been now my patient for more than 20 years. It's ever since I moved to London from Toronto. So he's a 34, at the time I met him, he was a 34-year-old truck driver, and he presented with a massive heart attack. So he had, and in retrospect, his father and two uncles died of heart attacks, all under the age of 50. His cholesterol was over 10, and his LDL was 8.5, and really was not, he looked like he was in good shape. His, family doctor didn't think much of it, didn't treat him. And then, he, at the age of 33, had this massive anterior MI, 3 stents put in, then went on to statin, ezetimibe, and, broad spectrum therapy. We with his permission, and we wrote up his story for the Canadian Medical Association just to raise awareness of familial hypercholesterolemia. So he had these very thickened Achilles tendons, and he had the eyelid xanthelasma, so all the classic sort of features, the tendon xanthomas on the back of his hands, and then the corneal arcus. And we did, DNA testing. So when we do the DNA testing, we tested both for rare variants and for polygenic risk, and we tested for secondary factors. So he had none of the secondary factors, so no nephrotic syndrome, no hypothyroidism. It was just purely genetic in his case. So he had a splicing variant, the intron 14 variant of the LDL receptor, and he had this super high polygenic score. So on top of that, so he had like a big variant that was raising his LDL. And then on top of that, he had a bunch of little variants that were further raising his LDL to this sort of very high level. And so he had heterozygous FH with, on top of which there was strong polygenic risk. So this is then the picture of his DNA sequence. This is using Sanger sequencing, and the arrow in the bottom panel shows the actual position, which is affecting RNA splicing at a really crucial location. So there's no LDL receptor made from this allele, and so as a consequence, he's only functioning on half the normal number of receptors. So this shows his treatment over the years. On the far left, you can see the year. And then in the second last column on the right shows his LDL levels. So of course, untreated, his LDL was 8.5 in millimoles. And then on the statin, you can see it went down a little bit. And then we switched up the statin and we added ezetimibe, and it came down further. And then basically he was static for about the next eight or 9 years. And then really life changed when he became one of the first patients to be enrolled in the clinical trial for Acumab, a PCSK9 inhibitor. And there his LDL, you can see on statin ezetimibe plus Acumab, his LDL came down to 1.3. So this has really revolutionized his treatment. Fortunately, he's doing great. He still comes to see me. Lately, during the pandemic, I check on him through the internet, and he's doing fine. So FH is, we used to think of it, as I mentioned, as 1 in 500, but now it's more prevalent, about 1 in 250. In the severe form, it does have those skin findings and tendon deposits, early atherosclerosis, single gene disorder. There are 3 main genes: the Ldl receptor gene, which is around 85 to 90% of cases, the ApoB gene, which is then the ligand for the LDL receptor. So in those patients, the receptor is fine. It's the ApoB that doesn't bind properly, gives you the same phenotype. And then there are gain of function variants in PCSK9, That's about 1% of cases, or fewer than 1%. They're quite rare in my clinic. So there have been more now than 3,000 rare variants in these genes that have been reported in familial hypercholesterolemia. So if you want to diagnose it, you need to have a method like DNA sequencing, like next generation sequencing, because pretty much everybody has got their own version. It's not like sickle cell disease or sickle cell anemia where there is like one variant that explains, every case. This is pretty much everybody comes in with their own personal variant that then results in the same sort of phenotype. And classically, the heterozygous form segregates as an autosomal dominant. So that those those causative variants, one of those 3,000 that have been reported, raises the LDL, and it's almost 100% expressed. So it's like, rarely it can happen that a person can carry the mutation and they don't show a phenotype, but the penetrance is usually very, very high. And so then it segregates. You can draw this kind of picture. The mother is affected. She's a heterozygous carrier. 50% of the children will inherit the variant allele and will also show the phenotype. Now, there's a special kind of variant. So I showed you the single letter change, which is we can easily pick up with most sequencing methods. But there are also these bigger changes where, in fact, it's not just a single letter. In fact, it's like the whole gene is missing, or a big chunk of the gene is missing. So to the med students, I call this holes in your genes. These are like copy number variants or DNA changes. So these copy number variants, this is a study that we did from our patients where you have to have a special method that's actually especially looking for these, because you will miss them if you're just like looking for one letter at a time, reading letter by letter, and then the whole book is missing, the whole gene is missing. How would you even know? So here you need to change your tuning parameters, and you need to be looking. And in fact, we can do this through next generation sequencing. So here, out of 388 patients that had FH mutations, 10% of the mutations were of this type, the holes in the genes, the copy number variants. So you need to have a method that will detect both types, or you're going to miss those patients. So this is a map showing all the patients that I've seen in London, Ontario, since I opened my clinic here. And so in the middle of the slide is the map of the Ldl receptor gene, and then all of those little letter codes, and shown by the arrows, those are a different DNA variant or a different mutation found in a different patient. So, and sometimes we see the same recurring variant a few times, but mostly everybody comes in, they've got their own version of the gene that's causing the phenotype. These are all heterozygous variants. So on the top of the map, those are all the small single letter changes, and then underneath are those copy number variants, the holes in the genes, the big variants where in fact like half the gene is missing, or a whole exon is missing, or something like that. So again, you need a method that will detect both. So the other thing that we know is not just the Ldl receptor gene, although as this table shows, most of the mutations now are found in the Ldl receptor gene, but there's about 5 or 10% that are found in ApoB, some that are found in PCSK9. There's another gene called Ldl receptor adapter protein, which is about another sort of fewer than 1% of cases. And then there are a bunch of minor determinants. I should say that last year, this one, STAP1, was removed from the list. So it's a bit like when Pluto got downgraded as a planet. It wasn't a planet anymore. So that's the same with STAP1. So we used to think that STAP1 was an FH gene, but then some more evidence came out and mouse models and so on. So now we don't think it's an FH gene. So now it's off the list. But there's still these other genes that are the major or the minor determinants, which can cause a phenotype that looks like FH. So you need to be screening for all of these things. Okay, so those are the big, large effect monogenic variants. Now I'm just going to take a minute to explain polygenic susceptibility to you. So again, polygenic susceptibility, it looks the same, like when you sequence in a patient, like the genome's the same, and then at one particular position there is a DNA variation. Could be an A, could be a C. The thing that's different here is the frequency in the population. So these are like really common. It's like the ABO blood groups. It's like, there, 50% of people could have one form or the other. It's not that this like 1 person in 300 has this like, rare variant that screws up the whole protein. These are common variants that are usually, in fact, as far as we know, biologically or clinically neutral. And instead, or when they do have an effect, it is a very, very modest effect. It's like a tiny, tiny, incremental effect on your LDL level. Just raises it a little bit. So here, and you may have heard of these kinds of variants. They're sometimes called SNPs, single nucleotide polymorphism. So that's these common variants, okay? Most of the time, they're clinically neutral or biochemically neutral. But there's 3 kinds of people. So this is the thing, just to reiterate. You genotype then, or you run this, so you find that there are 3, and there's like lots of these people, and human curiosity being what it is, you're wondering, oh, okay, well, for this, is there something different about the AAs or the CCs? Are they different in some way? So you can do that now. You can like measure everything and everybody, and then you can just run it agnostically, and you've got, their height, their, like anything you can measure, and you can do this across the genome. So let's take an example. Let's take triglyceride levels or LDL levels that has a distribution in the population. You run your DNA markers of that type, starting on the tippy top of chromosome 1 and moving to the bottom of chromosome 22, and now we can do these like millions of them simultaneously. You can do it on a gene chip, or you can use a whole genome sequence. Most of the time, okay, here's one. Here's like the first one, okay? No difference. There's 3 kinds of people, but for this marker, absolutely no difference in cholesterol levels, no difference in triglyceride, no difference. Okay, scratch that one. Let's move down to the next one. Okay, eventually you get to one that looks like this. Hey, look, these 3 people are different. Oh, and the thing is, you don't even know, all you know about this marker is you just know its position in the genome. You don't really know yet what it is doing. And in fact, this is the way science is now being done. It's sort of like reverse. Geneticists think that this is forward. Biochemists think that this is reverse. But anyway, sometimes then you will find a locus and you can test it statistically. And then the question is, when you do like 6 million statistical tests, because you've tested 6 million loci, how do you show 6 million p-values? Well, you do it like on this, which is called a Manhattan plot. So along the bottom, along the x-axis is the position within the genome. Every one of those little dots is the p-value, or at least it's the negative logarithm of the p-value. So it's like pH except for p-value. So the higher the position on the y-axis, the more zeros in the p-value. Okay, it's a smaller p-value. And so you can see that there are then, in this example, some things that are sticking out. There's like, these peaks of significant p-values. You don't even know what the hell gene that is, but there's something going on there. So then you can go and, thank goodness we have the human genome map. It can tell us, oh, interesting, there's a zinc finger there. I never even knew about that there was a zinc finger there. And then look what it's doing. It's having some kind of effect on triglyceride levels. So this is in fact how genetics and how biology is being done. This is the so-called genome-wide association study. So, and so now for any trait, for all traits, they've all been mapped. There's like hundreds of these loci. Now the thing is that it's not having a whopper of an effect. It's not causing FH, but it raises LDL a little bit. So these are, in this slide here, it shows, okay, you get the zygote, happens at meiosis, and then you have the distribution of the alleles in the genome, and just by chance, and there are these, on this example, so 10 really important loci that will slightly raise the LDL level, So interesting, one of them is the LDL receptor. Now this is not causing FH. This is just like raising LDL from like 3.05 to 3.12. It's like a small change. You need a huge population to detect that. But it's also the LDL receptor. Interestingly, PCSK9 is on this example, ApoB. So those same loci were the big effect causes the severe disease, the small effect is still affecting LDL levels. And these are much more common in the population, in addition to everything else on this list. So you can then be like a very unfortunate person who has inherited cholesterol raising or LDL raising alleles at every single one of these. And just like, these are the people that when they're playing Scrabble, they're always getting the Q's or the Z's or the X's, or they're always getting 2s or 3, 2 or 3 of clubs when they're playing cards. So they get always dealt a bad hand. They're the ones that then have this agglomeration of these small effects that in aggregate are pushing their LDL into a level that would be similar to the single monogenic variant. And it produces a phenotype that looks like FH. And this is polygenic susceptibility. Okay, so when people say polygenic susceptibility, that's what they mean. And this exists now for diabetes, it exists for cancer, it exists for schizophrenia, it exists for any trait you can think of. And in fact, most of the genetic susceptibility is of this polygenic nature. Okay, so these are now my patients. Okay, so on the left-hand side of the slide, these are patients with normal lipids. So it turns out that this is the proportion, the 1K cohort, this is a normal lipidemic population. About 11% of them, we consider a high polygenic score to be the top 10%. So here, 11% of people have got a high polygenic score. So it works out, okay? This is the general population. We're using the 10th percentile, 11%, okay? On the right-hand side of the slide, these are patients that get referred to me with high cholesterol that some doctor thinks has got familial hypercholesterolemia. So in that case, we then break them down into mutation positive, like the big mutations that I showed you, and mutation negative. So for mutation positive, you would think that that mutation explains their FH. The number that have a high polygenic score is identical to the general population. Okay, so there's no skew of the polygenic risk. But the ones that don't have a mutation, they've got high cholesterol, but they don't have one of those big league mutations, 3 times as many people have got a high polygenic score. Okay, so that's polygenic risk. Okay, now if we had used a less stringent cut point for the polygenic score, we could have gotten even higher percentage, but then the problem is that you're going into sort of percentages like, 25% of normal people will also have such a high polygenic score. So we think 10% is a good cut point therapeutically. So now most people don't have a polygenic score, but a lot of people do. So this is then how it breaks down in my clinic. When people get referred to me with a high cholesterol and some doctor thinks they have FH, about half of them will have a big mutation that's shown in red, and then about a third of them will have the high polygenic score shown in blue, and then there's people that have other things. If the LDL is above 8, okay, this is the other point, that when you go to a higher level of LDL, it's a smaller proportion, those are almost purely monogenic, okay? So once you're above LDL, once your LDL is above 8, there's no number of Doritos, or you're basically a single gene, classic, FH person, okay? And there's no secondary factors, there's no polygenic risk, or almost no polygenic risk. So here, this is what we think should be involved, like if your patient is being referred to a specialty clinic and they think they have FH, this is really what should be done. You do your clinical assessment, you screen for your secondary factors, and then you do your targeted next generation sequencing for the major genes, the minor genes. You look for copy number variants, you look for polygenic risk, you measure Lp(a), because sometimes that will present as looking like it's a high LDL, and then you can look for weird things like plant sterol levels and so on. Okay, so that's cholesterol. Now, triglycerides. So again, we've been interested in triglycerides for a long time, so I've got probably about 1,000 patients with triglycerides over 10. So this is one of my patients. She was a grad student here at Western, type 1 diabetic, wasn't always taking her insulin as she should, came into the unit with a triglyceride level of 110 with pancreatitis. And so that would be like 10,000 milligrams per deciliter. So she was super sick, she was like, So she, anyway, admitted to the ICU, pressor support, started on insulin, fluids, ventilation, she was on the ventilator. Anyway, 3 weeks later, she was discharged. Her triglycerides were down to 1.6. So she was then one of these patients that had genetic hypertriglyceridemia. So the triglyceride levels up to that range, those are kilomicrons, and that breaks down to these 5 genes. 80% of them are lipoprotein lipase gene, two alleles affected, biallelic. Then there's GPI, HBP1, ApoA5, ApoC2, LMF1. Those are the 5 genes that can cause this type of severe hypertriglyceridemia that puts the patient at risk for pancreatitis. But then in addition, you can also get the polygenic variety. So the polygenic variety that I showed you for FH, you can also get it for hypertriglyceridemia, and in fact, it's even more prevalent in hypertriglyceridemia. It's almost half of patients, depending on the cohort. So your diagnostic method has got to be looking for both, like whether it's high cholesterol or whether it's high triglycerides, it's got to be looking for both the rare monogenic variants that I first showed you. It's got to be looking for copy number variants, which is like 5 or 10% of cases. And then it's got to be looking for single nucleotide polymorphisms to build these polygenic scores. So this is then the flow through my clinic here at University Hospital. The patient comes to the clinic, we see them clinically, they get their, biochemical testing. We then take their DNA. Every patient gets a next generation sequencing, the gene panel. We test for monogenic assessment, we do polygenic assessment, and then when the patient comes back to the clinic, then we go over the results of the genetic testing with them. And we find that, in fact, if we know that they have a monogenic form, that actually helps, for instance, with insurance coverage for getting certain medications for them. Okay, so for FH, for patients that are referred with hypercholesterolemia, like I showed you, about half are monogenic, about 13 to 14% are polygenic, and then about a third we still don't know. For hypertriglyceridemia, fewer are monogenic. In fact, it's only about 1% that are classic recessive, about 14% are heterozygous, and then 32% are polygenic. The rest have got secondary factors, or we're still trying to figure out what they have. So now in the last few minutes, just therapies. So we know that there is genetic predisposition to these severe deviations of lipids. The ideal gene target is something that is secreted by the liver and that the levels are high, and the risk when the levels are high, the risk is high. And so then it's easier to knock something down pharmacologically than to boost it up. So if you can then knock it down, then you can reduce the risk. So for everything on this slide, PCSK9, when the levels are high, the LDL is high, the risk is high. ApoC3, when the levels are high, the triglycerides are high, the risk is high. Lp(a), the same thing, the risk is high. ANGPTL3, it's more of a combined hyperlipidemia. When those levels are high, both triglycerides and LDL are high. So anyway, if you can figure out to knock these down, you can reduce the lipids, and then downstream you can reduce the risk. And you can knock this down either with monoclonal antibodies or with RNA interference. So here's the general graphic for RNA interference. There's 2 ways of intervening upon RNA. You can do it with short interfering RNAs, which act within the cytoplasm and through something called the RISC complex that degrades the RNA. So that's when you hear siRNA. These drugs, just as sort of a shorthand for you, if you then kind of dyslexically take siRNA, you can kind of misspell it as Siran, S-I-R-A-N, Siran. So any drug that ends with Siran, Inclisaran, that's an siRNA drug, okay? Then the other way to do it is actually to go into the nucleus to sort of abort the RNA before it even gets out of the nucleus, and that's using allele-specific oligos, ASOs. So those drugs end with sen or arsen. So Siran versus arsen. So for example, volanesorsen or pelacarsen. So those are ASOs, whereas Inclisaran is a siRNA. Okay, so PCSK9, very, very briefly, there's a couple of ways that you can hit it. You can hit it either in the bloodstream with a monoclonal antibody, or you can now go inside the cell with an RNA interference drug and knock down the RNA. And so this is Inclisaran. So Inclisaran is this really, potential for being a game-changing therapy. Injection every 6 months lowers the LDL levels by an average of 50%. For triglycerides, the ANGPTL3 is really important, was originally identified because of its role in triglyceride metabolism, but in fact, the genetic studies show that people who are deficient in ANGPTL3 have got low levels of triglyceride and of LDL. So here, buprenorphine, so this is you can see Orsen, right? Orsen, remember I told you, so that's a ASO, that's an RNA drug, that's an ASO. So it works in the nucleus, it lowers ANGPTL3, it lowers triglycerides, and in other studies it lowers LDL. I have an Acumab that's, again, the same target, ANGPTL3, it's a monoclonal antibody. This drug was recently approved by the FDA for patients with severe hypercholesterolemia. So this is an all-purpose drug. It lowers triglycerides and it lowers cholesterol as well. ApoC3, again, elevated when triglycerides are elevated. Volanesorsen, remember Orsen, volanesorsen, so this is an ASO. It works, it lowers triglycerides by about 80% through reduction of ApoC3, presumably through liberation of lipoprotein lipase, although I don't believe that that's all it does, but that's currently what people think it does. There's a conjugated version of this that is more targeted towards the liver that can be used with lower doses. And then there's another siRNA that does the same thing, that lowers triglyceride levels. So this table here shows the 4 targets, which are lipid targets that either directly, well, mostly indirectly actually affect lipid levels. So PCSK9 affects LDL, ANGPTL3 affects LDL and triglycerides, Lp(a) is a direct lipid player, and then ApoC3 has an effect on triglyceride levels. So those are the actual molecules that are targeted by these therapies. The next columns then show the kind of evidence that supports these as valid drug targets. And then the next column shows the names of the drugs that are either available for you to prescribe or under development in clinical trials, that hopefully some of them soon will be available to prescribe, that are extremely effective in targeting and lowering in a targeted way only the target, because they're targeting RNA. And then the effect on lipids. And then some of them, we know the PCSK9 inhibitors reduce cardiovascular risk. So my final slide, thank you for bearing with me, because I was covering both diagnosis and therapy in this longer talk. So dyslipidemias, hopefully you can just forget about the Fredrickson classification. If you ever knew it in the first place, I'm telling you now, you don't need to know it, you never need to know it. So just, is it high LDL, is it high triglyceride, is it some combination, is it something else? For the monogenic, those rare familial disorders where it truly is a rare single gene, there's 25 genes, 25 disorders. By far the most common is familial hypercholesterolemia. When you have patients that come in with a diagnosis of familial hypercholesterolemia, most of the time it is monogenic. Or at least there is a more even balance between monogenic and polygenic susceptibility. For high triglycerides, however, it's way, way, way more often polygenic, like hugely. Like the monogenic forms of hypertriglyceridemia are so rare that you can, when like your patient comes in with triglycerides of 10, you can, pretty much, it's like, betting on Bitcoin or something. You can pretty much bet that that person is going to have polygenic hypertriglyceridemia. So anyway, these lipids, the LDL, the non-HDL, moderate hypertriglyceridemia, Lp(a), they all raise cardiovascular risk. When triglycerides are severely elevated, that puts you at risk for pancreatitis. And now we have these ready for prime time drugs. We have the monoclonal antibodies that we know work. And then coming out the pipeline, probably within the next year, are going to be the RNA interference drugs. And it's an exciting time to be treating lipids. So I want to thank you for your attention, and also thank the organizers for inviting me to be part of this amazing symposium. Thank you.